You are now listening to Nailed It, the Orthopaedic Surgery podcast, featuring Doctors Jay Fitz and Wendell Cole.
Guys, hello everybody, and welcome to the Nailed It podcast. My name is Dr. Wendell Cole, and I have my co-host here,
Dr. Jay Fitz.
And we are both orthopedic surgery interns, and we created this podcast to go over current orthopedic topics. You know, we're going to have orthopedic surgeons on here, we're going to have reps, we're going to have a lot of different people on here, and this podcast is for residents, it's going to be for medical students as well as attending. So please subscribe to this channel and definitely to get your orthopedic knowledge up. Now, I'm with Dr. Jay Fitz, and have you seen the new Avengers?
Have I seen the new Avengers? Okay, so let's go ahead and get this out there. Something y'all can know about me. There's only a few things I'm more passionate about than orthopedics, and Marvel Comics just happen to be one of them. So I've seen the Avengers movies about 3 times now, sir.
Man, 3 times?
3 times, and I might go again.
Did you check it out in Dolby? You know, they have when the seats vibrate and you know, all that stuff.
You got to get the IMAX. You got to do the 3D at least one of those times. I can't do it all 3 times because, you know.
Man, see, I don't want to ruin this for the people listening to it, but by the time this comes out, they probably should have seen the Avengers, right?
If not, you are a bad person. I don't know if we need you in this field. No, I'm just kidding.
Oh, guys, go ahead and tell them about today's guest, Dr. Fitz.
Yeah, we have a great one in store for you today. We have Dr. Gary Stewart from Resurgence Orthopaedics. He did his residency at Drexel University, and he did his fellowship with Stephen Conte. And today we have him talking about ankle fractures.
And we kind of dive all the way into ankle fractures. We talk about what you're looking for on physical exams, x-rays, radiographs, the different type of x-rays to get. We talk about classifications, non-operative versus operative treatment, and we also talk about surgical approaches. So guys, sit back, listen, and you know, without further ado, go ahead and enjoy our conversation with Dr. Gary Stewart. All right, welcome everybody to episode 1. You actually are our first guest here, Dr. Stewart. Thank you so much for
Spring 94
for coming on the show. I'm with, my name is Wendell Cole, and I have my co-host here,
Jamal Fitz.
And we're going to do our first episode with Dr. Stewart. We're going to talk about ankle fractures. Now, we actually have some questions that we wanted to start out.
Shoot.
You know, we love starting off, kind of getting to know our guests before we hop into everything.
Yep.
So I'll let Jamal ask this question.
Yeah, I think this one's a pretty good one, Dr. Stewart. A lot of residents probably kind of trying to figure their way out through orthopedics and trying to see which route they want to go.
Yep.
So just for you, how did you get to choose your subspecialty in ankle?
Well, that's a great question because many people always ask me why did I go into foot and ankle? You know, well, just like everybody else, I thought I probably wanted to be a sports doc. You know, I played football in college and I tore my ACL, and the first orthopedic surgeon showed me how he was going to fix up my knee, and I was like, man, this is cool. This is what I want to do. So I became focused on doing orthopedics. I mean, I walked into medical school, you know, wanting to do orthopedics. And so as I got into the field, I was like, man, this is really great. And then I did a rotation out in Pittsburgh with Stephen Conte, who ended up being my fellowship director. And, you know, I kind of was like, wow, why are you doing foot and ankle? And he's like, well, it's different every day. You know, after a while, and I always call sports docs sports miracle doctors, you know, but you don't have to walk on your hands, okay? So every day I come in, it goes from reconstructive, it's trauma, it's sports related, you know, and I just, you know, there's a million ways to fix a bunion, you know, and so I get bored. I mean, I have a little ADD. As well as OCD, all the Ds.
Yes,
and
me too.
yeah, and so I get bored, you know, and I really do appreciate someone who does a good rotator cuff. And I appreciate the guys who do good ACLs because they did it on me. But I just couldn't see myself doing the same operation every day. Now, they'll say it's not the same operation every day, but you know, for me, in my experience, in my worldview, I wanted something that would challenge me every day. And believe me, foot and ankle does. I mean, you deal with medical comorbidities. It's constantly changing. I'm also a practical guy. I realized I probably wanted to live in close to a city. I grew up near Philadelphia. Go Eagles. And
Oh, yeah, I know you're happy now.
I am real happy about that. Oh, you see that? Yeah, I'm happy all day. And so I knew that I probably wanted to be either in or close to a metropolitan area. And I also know that there's a lot of orthopedic surgeons out there. And the sports field has a lot of people that like to do that. We all kind of think the same way. And I figured I like foot and ankle. At the time, there weren't a lot of foot and ankle surgeons out there. I'm practical. I want to have a job, right? I mean, so I was like, man, I like this field. There's not a lot of people going into the field. All the people in the AOFAS were really friendly and cool. And I said, hey, that's my specialty.
Hey, man, now you're here, because it's crazy. We actually rotated with you. And you
strong students. Very good. Very knowledgeable guys.
There we go.
And the second question that I have for you is, do you have a quote that you live your life by?
I do.
Why?
I do. Well, you guys can tell that I'm relatively short of stature, and I did play college football. And so my dad used to always tell me, as I maybe be a little bit nervous about getting out there, that it's not the size of the dog in the fight, but it's the size of the fight in the dog. And believe me, every day you're going to need that internal dog to kind of get you moving, because it's challenging. You know, life is challenging in general. Eventually, you guys, if you don't already, are going to have a family. You know, you're going to be taking care of people. And everybody I operate on, I truly take it to heart. I mean, you are trusting me to open up your body and fix you. I mean, that is mind-blowing if you really think about it.
Yeah. Yeah. Yeah, that's great. I love it. And one last thing, so we want to kind of just do a one-liner before we go in, right? Like, you know, you go into a hospital and you're rounding on patients and you have a one-liner. So, for example, mine may be 24-year-old male about to start orthopedic surgery, loves to travel, loves to be with family and friends. Jay, what might be yours?
Oh, man. 27-year-old, about to go into orthopedic surgery, enjoy family, big foodie, big nerd. I love my comic book movies, and that's me in a nutshell.
Yeah, well, I guess, I guess I could go and say my age. I'm a 43-year-old orthopedic surgeon who loves his family, loves God, and enjoys what he does, and lives life to the fullest every day.
Great. Awesome. Great. I love it. So kind of what we want to do now is kind of switch gears and get into this ankle fracture.
Let's do it.
Which everybody wants to kind of talk about. And what we want to do is kind of just start off like a little case presentation, right?
Great.
So we have here, say, a 56-year-old obese woman comes to the ER. She had a ground level fall, and she's complaining about ankle pain. And orthopedics are consulted. Kind of walk us through what would be the next steps. You know, as you the physician.
Well, I think one of the most major things, as you were talking about being in a hospital setting, is always remember that you are a doctor. So you always start everything with your history and physical, and so you have to look into past medical history. You know, if that person has a medical comorbidity like diabetes, that's going to change your approach. Past surgical history, whatever they've injured on their ankle, are there other incisions surrounding the wound? You got to do run through your whole history, and in terms of your physical, actually do the exam. I can't tell you how many times I've followed up on folks, and I won't say any names, where I'm like, they couldn't have possibly done an exam, because now it's hours later and I see that it's an open fracture. And so definitely remember you're a doctor. Remember what you learned in medical school. History and physical will give you the majority of what you need.
So for ankle fractures, what are the things that we want to key in on and not miss?
Right. So we talked about making sure you go through your history, and we can jump to physical examination. You want to look at the skin, number one. You're going to look and see if there's any blisters, and if there's any incisions that look like it could, not incisions, but lacerations that look like it can communicate with bone. And, if there's any exposed bone, you're going to make sure that you get your imaging studies. In an ankle, you need to get at least 3 views, your AP, your lateral, and your mortise view. If you don't have 3 views, you have an incomplete radiographic evaluation. And so then you want to look and see if you think this is a surgical case or not. So when you're going back, make sure you check out your skin. Is there blisters? Is there a lot of swelling? Is there any lacerations or anything that could be dangerous? And then you're going to get your x-rays. You're going to take a look at your x-rays, your 3 views. And then from there, you're going to use your training and see if it's stable. Also, you got to make sure that if they're neurovascularly intact. You want to make sure that you check your pulses. Make sure that their sensation is there. You want to make sure you do a motor exam. And so you have to do all those things and make sure you document before you start trying to jump to whether you're going to do surgery or not.
Right. So if we can kind of rewind a little bit and focus in on, I guess we can talk about the X-rays.
Mm-hmm.
So the different X-rays, how they're taken, and then what you're looking for on each one.
Right. So your AP is a standard. You have your ankle in neutral, and then you're getting just a straight kind of head-on view of the ankle joint. Your AP, you're going to have approximately 25 degrees of internal rotation of the ankle, and that's actually your real AP of the ankle joint, if you think about it, because the talus has some internal rotation. So you have to do that, change that rotation, take that rotation out, and that'll give you your ankle itself. And then you're going to take your lateral. And so the most useful of all these, to me, is usually the mortise view. And you have to have all three, but the mortise view is where you're going to look for your medial clear space, and you're going to look for, you're going to end up looking for your tib-fib clear space. And so those are all things that are going to give you some info into maybe the stability of the ankle, whether maybe the deltoid or the syndesmotic ligaments are involved. Your lateral, you're going to take a look at your posterior malleoli. You're going to see if there's a fracture in that area, in the posterior aspect of the fibula, if there's any displacement there. And so then again, you're starting to get your mind into what you're going to do surgically.
And in those type cases, at what point, and also how would you go about doing stress views of the ankle?
And that's great. So you go and you get your regular views, and you're like, man, that looks a little bit funny. And so I do either a gravity stress view, which is easiest in the office, and where the patient kind of lays on the side, and you look at the fibula and see if the fibula distracts with the gravity, pulling the ankle down. And you have to really kind of train your x-ray techs to get the proper view of the ankle so you can see if there's any displacement. Or you can do an external rotation test. And that's usually something you have to do with the patient in some form of anesthesia, because that'll hurt, obviously, if they have a fibular fracture, and you're checking to see if there's any widening of your tib-fib clear space or or widening of your medial clear space there.
So just to I guess make sure I have this down right, for when the patient's laying on the table, say for example they have a fracture of the right ankle, you want to get the gravity view. They'll be laying with their right hip facing the table, and
that's exactly right. Yes, sir.
And they're I guess they're just from their ankle would be hanging off off the edge of the table.
Yes.
And it's just the gravity is just putting in that external rotation.
That's right. It's putting a stress on it.
Now, is there any certain amount of degrees of external rotation we want to necessarily get with the stress view, or are we just looking?
You're going to just see if it moves, if you have widening of your medial clear space, or if that tib-fib space opens up. You're just going to look and see if it opens up. And so you're looking at the numbers, right? So all of you guys know that your medial clear space needs to be less than or equal to 4 millimeters. And if you're looking at your tib-fib clear space, it needs to be less than or equal 6 millimeters. And that's on your mortise view.
Great. And so what I wanted to also do is, so once we have our x-rays, we have our AP mortise in our lateral, and we look, and then now there's all different classifications. We were kind of having a conversation before this started on different classifications of ankle fractures.
Right.
Could you kind of take us through?
Well, what I would say is, and all of my residents know, and all orthopedic surgeons have their different ways of approaching things. And I'm the last one to say that I have everything perfect. But I'm not a big classification guy. I think that the inner and intra-observable reliability on some of the classifications aren't necessarily as high as you like. Now, I agree that when you're at some conferences, you want to maybe know your AO classifications. To be honest with you, whenever I'm going to a conference and I have a fracture I'm presenting, I always have to go back and make sure that I'm looking at what the AO classification of that is. You also have your Logie-Hansen classification. That is based on kind of the mechanism of injury of an ankle fracture. And in some cases now, I'm sure there's some people that really like the Logie-Hansen classification. I'm not a big proponent of it. I believe in more recently it's kind of been debunked. But I think that in terms of the Logie-Hansen classification, the supination adduction would be something that I'd look for, because that gives you your vertical shear on the tibia, and that'll change the way you may fix that tibia fracture on your medial mal. My favorite is the Weber, and that's probably the favorite of every intern, resident, fellow in the world.
Yes, definitely.
Yes, we all love, or Weber. I mean, I'm not German, so we'll go Weber. And, your Weber A's, which are below the ankle mortise, Weber B, which is at the ankle mortise, and the Weber C, which is above. And to tell you the truth, I think if you're going to look at a classification scheme and you want to be able to communicate, then that's probably the best one, because everyone basically knows it. You can have a general idea of it. And if someone gets off of it a little bit and doesn't really know it that well, it's kind of hard to miss A, B, and C. When you start talking about Logie Hansen, I think that's just, pimp fodder.
Right.
You really look it up, and you've got your second year resident probably doesn't know that, and you kind of make them want to read when they don't know it. But I think it's important to know that those exist. To at least historically, in my opinion, for the Logie Hansen, and it's impressive when someone can rattle it off, and I get a general idea of the mechanism of injury. But I'm a Weber A, B, C, and we can work from there.
And this is kind of a side question. Me and Cody was actually talking about this earlier. At what point would you start considering these fractures? You would consider them like a pilon fracture?
Right. Well, a pilon fracture is a damage to the articular surface of the tibial plafon. It's a tibial plafon injury, and they tend to be from an impaction type injury. And so think of it inarticular, and yes, technically a medial mal fracture is inarticular, but it's the mechanism of action to me that's making it a pilon fracture. And if you look at that supination adduction, it has an impaction component. So that's, I would say, on a spectrum of that.
And one of the interesting things that we were talking about actually right before this started, because both of us before we were coming here were like, man, our foot is an actual supination and then you get adduction. And really quickly, and maybe for people who can visualize this if they're listening, can you kind of go over that, like the position of your foot in these different classifications or these different mechanisms?
Right. So if you're thinking of your supination adduction, you've got to think it's a rotational type injury. And so usually the foot is planted in all of these. And so whenever we're describing them, we kind of are acting like we have our ankle model and we're showing the resident in space. When in actuality, the best thing to do, and I've seen a kind of an interesting research that was done on, I think it was YouTube videos, where they showed different mechanisms of injury on that. Now that's the way to look at it when the person comes down. Or on a football field when the foot is planted and there's a rotation where there's an external rotation of the foot, but the foot is really an almost internal rotation of the tibia. And then the other one would be an external rotation of the tibia, but the foot's still planted, but we describe it as an internal rotation of the foot. So I would think that it probably would be best to be on video. That would be almost impossible, I think, on a podcast to really do. Because you can't, it's like, you're like, what is this fool talking about? So I think that that is something on video that I think you probably, if you're listening to this, you probably should take a look on a video for that.
Okay. And what are different types of, I guess, ankle fractures, right? Because you have trimalleolar, bimalleolar, you might have like avulsion. Like what, if you, just in general, can you just kind of quickly talk about the different types of fractures?
So we have our bimalleolar ankle fractures, which obviously are from, let's start from the beginning. Let's start, say, just a fibula fracture, where you may have a fracture of the lateral malleolus where there's a fracture line going through it. You can have a displaced fracture, such as your Weber B's, A's, and C's. And when we talk about avulsion fractures, quite commonly we're thinking of like one of those ankle sprains where you see a little bit of the fibula that comes off, and so that tends to be more of a sprain, doesn't require operative fixation. You have your fibula fractures, as I was saying, that go through the fibula and they're displaced, and they have to be, in my opinion, to do surgery on either unstable, where you have the movement on our external rotation or gravity stress test, or displaced by about 2 millimeters. Or you have your bimalleolar equivalent, in which you have your fibula that's injured, however, you have a deltoid injury. All right. And so as you guys are coming up probably through your training, you'll see that the deltoid is becoming more and more repaired. We never repaired it when I was in training, and now I am beginning to repair it based on what I'm seeing in some of our AOFAS courses and the AOS courses. Then you have your trimalleolar ankle fractures. Now, let me go back. Bimalleolar ankle fractures, I talked about bimalleoequivalent because you have medial instability over your deltoid. And then you just frankly have your bimalleolar ankle fracture where 2 of your 3 malleoli are fractured. So your malleolus consists of your fibula, your medial mal, and your posterior mal. And so you can have a bimal that's a fibula and a posterior mal. And so that's where you can't just think of your bimalleolar ankle fracture as medial lateral, because a bimal, posterior, is, and we are finding is very important to the stability of a fracture. And then you have your trimal, which all 3 of them are injured. And so what becomes important in that is how are you going to fix it?
Right, perfectly. And then I was alluding to what my co-host here, Jamal, was talking about. So how do we know what to fix versus non-operative?
Well, non-operative treatment tends to be an isolated lateral malleolar fracture without medial malleolar involvement. Now, those indications to fix those are based on stability. So you have to do your stress tests. And if you really truly just have an isolated fibula that's minimally displaced and appears to be stable and is not moving on any of the tests we described, then you can treat them in a cast. I think sometimes people operate on them and maybe they feel like they could get more early mobilization, but really an isolated fibular fracture that the other structures are stable, you don't necessarily need to do anything surgically for.
Does this matter whether it's a Weber A, B, or C, or just any?
Well, it's an isolated fracture with 2 millimeters or less of displacement. Okay. So if you have a fibular fracture that has 2 millimeters or less of displacement, that's not surgical in my book. But that is controversial. I mean, that is not hard and fast, because I have had some that look to be minimally displaced. Maybe there's some medial clear space widening, and I look at the patient. I'm like, this person is younger and is going to be trying to move, and I maybe want to mobilize them faster. Or this person is 90 and can likely do well with no surgery, or medical comorbidities.
And as far as the non-op treatment, is it usually a boot? And I guess for about how long do you usually have them in it?
And I believe that this is probably, again, style points for the doc. I tend to try to put people in casts for at least 2 weeks. I do that as much as for their mentality as stability to fracture, because a good air cast boot fitted appropriately is, in my opinion, as good as a cast. And I believe there's literature out there to support that. However, I always kind of make a joke, and I hope your listeners don't think I'm blaspheming. That is not my intent. But I always swear that Jesus, if you had an air cast boot and you told him not to walk on it, would walk on that thing. I'm telling you. I mean, it's something about the treads. It's something about the fact that it's a boot. And so I always throw them in a cast, and I kind of say, hey, you've got a fracture here. If you don't want surgery, don't walk on it. Something about a cast will keep people off of it, or at least not trying to do as much on it. And then I'll transition them into a boot. And in general, at about 6 weeks, I will let them weight bear, but it all depends on a weight bearing x-ray that I get in the office. And if it's that unstable, then you need to fix it. And so if I'm going to go conservative in their lateral malleolus fracture with 2 millimeters or less displacement, and then I get a weight bearing x-ray at 2 or 3 weeks and it looks like it's starting to drift, and everyone that takes care of ankle fractures, they can start seeing that drift. You start seeing it look like, is that medial clear space widening? And the next week you're like, is it? And then all of a sudden you're like, oh my God, it is. And now you're like, doggone, I should have just put a plate on that thing. So about 6 weeks to answer your question.
Okay, so one of the non-operative indications are isolated fibular fractures
with 2 millimeters or less displacement.
What are there any other non-operative indications?
Well, I mean, if there is maybe a slight medial malavulsion type fracture. But in my hands, if you have a medial malleolus fracture, you really have to start looking at the mechanism of injury and what other injuries may occur. And there are some people that may throw a medial mal in a cast. But in this day and age, I mean, when you can put, I think you should put screws in there, because you have that joint fluid that can end up bathing the area of fracture and maybe not letting you get your fracture healing. You can also get little flaps of periosteum in the fracture site on the medial mal. And so sometimes I have someone that is a minimally displaced medial mal, and I'm like, you know what, I'm going to go ahead and open this up, and there's no doubt there's always some periosteum that has flipped down and I got to push out, and it's just not really as minimally displaced as I thought it was. And so I really believe, for non-operatively, that's really the indications. Now, operatively, and that's what we're talking about. I mean, that's why we got in this game, right? You get to cut people open and fix them. So, bimalleolar ankle fractures are operative. Bimalleolar equivalent, like I had mentioned earlier, with a lateral mal and a deltoid injury. You've got your trimalleolar ankle fractures, and you've got your unstable syndesmotic injuries, right? I mean, you can have a syndesmotic injury without necessarily having a pure fracture. Although if you look, there's probably some fracture somewhere, or open. If you have an open ankle fracture, you got to do something about it. Got to wash that out, and then provide some hardware in there.
Okay. And I guess can we just kind of go over some of the different options you might use as far as hardware for those different types of fractures as well?
Great question. And so if we're talking about a fibular fracture, we are talking about, traditionally you can go laterally, just make a straight lateral incision, get down the bone, make sure you avoid any branches of the superficial perineal nerve, don't create any subcutaneous flaps. You find your fracture line, you clean that up a little bit, and then maybe you could throw a lag screw, and then you can put a lateral plate. Or you can do a posterior approach. The posterior approach is supposed to be more stable. It's called an anti-glide technique, where you go posteriorly and you put a plate posteriorly to provide fixation. Now, that has less hardware prominence because you're going posteriorly, but it also has been seen to have some perineal irritation. And then if you go straight laterally, it's not the strongest of construct like an anti-glide plate might be, but the hardware is less. If you go laterally, the hardware is more palpable, and then you may have to remove it. So there's cons and pros, and really it amounts to what you're more comfortable with, and sometimes and often the fracture pattern. Medially, if you have, say, it's just a straight bimal, and you've got one of your SERs or something like that, and you've got that medial mal, then you just you can open it up, put 2 screws in. You can do a tension band technique, K-wires and a tension band, or you can put, depending on a fracture fragment, some people may even put a washer in with a screw and think that that's okay, because a screw is really kind of a small plate. I'm sorry, washer, is really a small plate, and so that's what some people do. And so that's a way to maybe go about your medial mal. Posteriorly, we used to kind of do a thing where you do a reduction and you make yourself feel good with the medial mal reduction or your fibular reduction specifically, and you say, oh, it's stable. Well, we're finding out that it's nice to go in there and open up and rigidly fix it, maybe with a small plate or screws. And so you want to get rigid fixation posteriorly, because it's shown that if you fix posterior malleolus and the ligaments are there, that gives you your syndesmotic stability. So those are some ways to go about it. Of course, you could we all open up a book and look it up, but it's always good to be running and maybe in your car and listen to some orthopedics too.
There we go. It sounds perfect. Now, let me ask you this, because this is something that's coming. I'm sure you see it all the time. Mm-hmm. How would the treatment plan change if this patient had diabetes?
Oh man, you guys have done your homework. I love it. Not making it easy on me. And so, diabetes is an epidemic in this country. I mean, it seems like every other person I see has diabetes. And so let's go back a little bit and talk about your physical examination. You want to do your Symes-Weinstein monofilament. You want to have your 10 gram or your 5.07 Symes-Weinstein monofilament, and that allows you to know if that person has protective sensation. So that's something that's part of your physical exam. It should be when you're examination foot and ankle. But if you're going to have a diabetic, you tend to be more aggressive with your fixation. There's an idea that because that person's a diabetic and maybe they may have some wound complications, that maybe you can treat it non-operatively. That's the exact opposite. You need to be more aggressive. In fact, you need to provide more fixation. Some syndesmotic screws, not necessarily to fix the syndesmosis, but to give you more points of fixation. People are putting their quadricortical screws in. Some people will put their medial malleolar screws that they put in and put them all the way to the lateral portion of the tibia. And you just got to keep them off of it longer. So a good rule of thumb is to keep them off of it for twice as long as you would be somebody else.
And in those cases, how do you sometimes, if it comes up, I know it's something that you don't want to deal with, but if that patient end up getting an infection or some sort of non-union, how do you usually go about that as well?
Well, I was trained by some good people, and they always told me not to put your head in the sand. I mean, it's real easy to do surgery, and then there's a diabetic, and there's some drainage, and you're like, you kind of throw them on some antibiotics and hope it's an A-OK. Well, no, if you get an infection, go in, wash it out, clean it out as soon as possible. Hopefully you'll be able to salvage the case. If you get a non-union, maybe you didn't provide enough fixation. Also, you got to take a step back. Was that patient, metabolically optimized? What's their vitamin D? What's their calcium? Do they have any infection? So you get your CRP, your SED rate, your CBC with a manual diff. Check their albumin. Is their albumin enough? Do they have their protein levels? You check their lymphocytes. And so you're looking at all of those things to make sure that you've properly optimized the patient, especially if it's a non-union. Because was it a failure of fixation? Was it the patient? In terms of having the building blocks to heal? Is there an infection? So those are the things you have to look at. Hey, this is, there's a reason why we get informed consent. And if you look at those informed consents, you see all kinds of risks in there. And you really need to tell your patients that those are risks, because all too often, I don't know if it's the medical shows that we have now where somebody's got a pilon fracture and they have an X-fix on 1 week, then the next week they're playing a game. You're like, whoa, he's running already? So I think that, patients, you have to manage the expectations.
That's perfect. That's kind of leading into one of my next questions. What is just the overall, maybe not in the diabetic patient, just the average patient that you deal with this with, what's the type of prognosis we're looking for, with the complications they might deal with, time to back to driving and different things like that?
Those are all great questions. So number one, what I always tell the patient is that the ankle will never be the same. It's never the same. There's always some form of cartilage damage to the area. And as you guys go and read some of your basic science, you'll see that. And it's been shown to really help the patient out, you've got to fix it. It's going to get ATF. It's got to be anatomic. It's got to be there. And, the fixation has got to be there. So I think it's AFT actually, but I won't say the F. But everyone I think knows what that is. You got to get it perfect, because it's been shown if you have even 1 millimeter of displacement, that increases the contact forces in the ankle, leading to arthritis. So you got to fix it right. And so in general, my protocol is, and again, everyone will fix the gumbo differently. Mine is I operate on you and I see you about 10 to 14 days. We check your incision. If it looks good, we take out the sutures. We have the long conversation about the boot or the cast, because I would rather put you in a boot so that you could start having range of motion. But if you're going to tell me you're not going to be able to do it, and just knowing my patient population, I won't let you. I'll put you in a cast for 4 weeks after that. Now, there are studies that show that you can weight bear, and it's just that you just have to be careful as a physician what you tell a patient. If you tell them they can weight bear, in their mind, they're like, oh, I can start shooting ball. That's what the people think. So at 6 weeks, then we start really getting it on. I'm putting you in a boot. I'm telling you get your motion. And most people will get all their motion back. By about 3 months, I tell them that they'll probably be walking in a regular shoe. But it takes really a full year for your ankle to be that way. And people are just shocked. I'll see people at 3 months like, my ankle's still sore. And I'm like, well, you broke your ankle. And all too often as orthopedic surgeons, we fixate on we allow the patient to fixate on the bone because we have an x-ray and they see the broken bone. But what I always try to tell them is that in order for that bone to be broken, you've had to injure some of the soft tissues, and that really hits home with them. And then they really can get into their physical therapy with that.
Yeah. Now, not to rewind, but I guess I'm going to rewind a little bit. And because I was just looking here at this, it's some notes that we wrote down. Now, when you're going in for operative fixation, not operative fixation, but when you're going in to operate on these different fractures, is there a certain order that you approach the fractures in? Like if you have a fibular fracture plus a medial mal and a
absolutely, and I want to make sure we get to talk about the syndesmosis too. So we'll talk about that. But I generally will start laterally. I'll start laterally. I'll try to get my fix the fibula, because that'll give me the length that I need for the ankle fracture. And quite commonly, if you have basic ankle fracture, once you get that fibula out the length and you have rigid fixation there, the medial mal kind of finds its position. Now you still got, in my opinion, have to open it up, look at that shoulder portion, make sure there's no impaction. You want to make sure there's no periosteum flipped in there. If you are having trouble laterally, quite commonly the deltoid may be stuck in the joint, especially if it's one of those bimal equivalents and you don't really have a medial mal fracture and the deltoid's torn. It may be flipped up in there. And so if I see a wide medial clear space and I know that there's been some injury, I may sometimes start medially and I'll flip that deltoid out of there, and then now I repair the deltoid. If it's a really comminuted, and for those that don't know a whole lot about orthopedics yet, if it's one that has a lot of fractured pieces in there on the fibula, it's sometimes hard to judge your length. And so I'll go in medially first and get that medial fixation. And so that'll get sometimes your talus underneath the tibia in a good position and give you an idea of what you may need to do laterally. And so that'll be a case I'd start medially. Sometimes if there's a bad posterior mal fracture, I will go with a posterior approach, and then I'll go to the posterior mal and I'll get that reduced. That helps get your fibula out the length. And then I'll fix the fibula with that anti-glide technique if I'm able to. And so that would be a case where I would pick each malleoli and do it first at some point in time.
Now, do you operate on every posterior malleolar fracture, or is there a certain threshold?
Right. So I do not operate on every posterior mal fracture. There was a movement, and still may be in some circles, where it's like every little ditzel we'd fix, because we were finding out that the PITFL is the strongest portion of the syndesmosis, and so you have to get that in alignment, so that also helps the stability of the syndesmosis. But in general, the rule is 25%. If the posterior mal is more than 25%, you need to fix it. Also, what I find to be more accurate is a posterior stress view. I mean, you're in there, you've got the x-ray, you're looking on a lateral. Try to stress it. If it's unstable and it's opening up, then you got to go back there and fix it. I'm fixing more and more now than I have before, for those reasons of stability of the ankle. And so, yes, 25% or instability would be the test answer, but we're fixing more and more posterior mal fractures.
Okay. And I would love to wrap this up by having you talk about the syndesmosis.
Good.
Just kind of letting you.
But the syndesmosis, we're finding more and more the importance of it. And, the big question is, we get that fibula at the length. We fix that medial mal. So what about the syndesmosis? Intraoperatively, you may do your cotton test and stress it, or another external rotation test, and say you have some widening of that syndesmosis. How do you fix it? And so if you have a posterior mal fracture, some of the best thing you could do for yourself would probably be to go ahead and fix that posterior mal. If the syndesmosis is unstable and there's no posterior mal, it's just frank syndesmotic injury, you could put 2 screws across the syndesmosis. The thing you have to, or one, it's just that you have to get it. The fixation is important, but we're finding that the reduction of the fibula into the incisura is the most important portion. And so what we were finding is that we were thinking we were just kind of fixing it, but sometimes you actually have to open up the syndesmosis, remove any soft tissue from there to make sure you get a good reduction. And the way to fix it, I've been trying to figure this out, looked at a bunch of studies, and to me, it really seems that you have to have your anatomic reduction of the syndesmosis to be important. Whether you go with some suture techniques, since we want to try to keep you guys out of trouble with any proprietary names, any suture button techniques or screws. I tend to do the suture button techniques now because I kind of feel like the fibula may kind of work its way into the right position. And when you fix it with screws, it's a rigid fixation. And so I kind of think that the suture button probably gives you an ability to kind of get that fixation in there and kind of work its way in, and you don't have to remove it, but it's costlier. But whether you use 1 screw, 2 screws, quadricortical, tricortical, suture button techniques, you just have to get it reduced. And it's very important. You can't let the syndesmosis go, or you've done a disservice to your patient. Remember, they trusted you to fix them.
Perfect. Jamal, do you have anything else you want to cover?
Actually, you know what? I actually do. I have one quick question because it was something I saw when I was doing rotations that I thought was kind of neat. I've never actually seen one in person. I just kind of saw the aftermath. What are your thoughts on the ankle? I think it's ankle replacement.
Absolutely. We definitely. I mean, that we do them and I do them. I think at this point it is a reasonable technique. And we've gotten to the point where it is a good technique for someone with end-stage ankle arthritis. There are some that are very aggressive, and there are some that are less aggressive with it. But we're slowly we always say ankle fusion is the gold standard. However, how many of us want our ankles fused? And it's to the point now, there's a lot of ankles on the market. I think you just have to get comfortable with it. And and everything has complications, but I believe we've managed that to a point now. 10-year survivorship is at a good position now. So I think that people always like to ask me at courses, would I do that on my family member? In fact, they asked me at the course we had here a couple of weeks ago. Absolutely, yes. Would I want one? Sure, if the option was the option was a fusion versus motion, and I felt that I could follow some of the things. I mean, right now I'm blessed to be able to be as active as possible, but hey, 20 years from now, if those old ankle sprains that I had while playing ball creep up on me, hey, I'm gonna find one of my colleagues to that total ankle in there. And so yes, many of the ankle fractures that we fix end up needing total ankles.
Yeah.
Awesome. Well, I think that was great. You got to soak in all this knowledge while I had the chance. I really appreciate you coming to speak with us today.
Thank you for being a guest. And just in case, how can the people reach you if they want to reach you and kind of find out more about Dr. Stewart?
Absolutely. They can go to resurgence.com, and I have my website there. We do a lot of things in the community as well. I would encourage any of the young orthopedic surgeons to, that old saying, too much has been given, much is expected. So we are truly blessed to be able to do what we do and always try to get back. And, go Birds.
All right, guys, thank you for listening to episode 1 of the Nailed It Orthopedic Podcast.
And for show notes, go to nailedItOrtho.com. And do not forget to subscribe. We are nothing without you guys. All right. Drop a note. Leave an email at nailedItOrtho@gmail.com. We're looking forward to hearing from you. Take care.